Hi, welcome to the part 4 of the lecture for Pathology of Female Reproductive System. I'm going to continue with ovarian neoplasms, and there are some other lesions as well in the ovary, such as follicular cyst, corpus luteal cyst, and you also need to know about polycystic ovaries, but in this lecture I'm going to concentrate on the neoplasms. So I'm going to talk about serous tumors. Serous tumors may be benign, borderline, or malignant. Microscopically, it may be large, up to 40 cm in diameter, spherical or ovoid mass. If it's benign, it has a smooth, glistening inner lining, and if it's malignant, it has a small, solid nodularity and papillary projections. This is important in gross examination of the specimen, so you can get clues whether it's benign or malignant based on the gross examination of the specimen. Microscopically, if it's benign, it's lined by single-layered tall columnar ciliated epithelial cells, and it's filled by serous fluid. And in this case, it has multiple papillary areas as well, with fibrovascular core, as you see here. Okay, and if it's malignant, it is multi-layered and with multiple papillary areas, but it doesn't show in this picture. So it can present as atypical cells invading the stroma. So you can see these atypical nests of cells invading the stroma. Mucinous tumors can present as a large cystic mass as well, and it can be multiloculated, and it's filled with gelatinous sticky fluid. And microscopically, it can be benign, lined by tall columnar intestinal-like epithelium, also known as intestinal-like mucinous cystadenoma, or it can be lined by focal ciliated cells with papillary architecture, which is also known as Mullerian mucinous tumor. If it's malignant, it's usually the intestinal type, it has a solid growth, and it invades the stroma. Endometrioid tumors are associated with endometriosis of the ovary. Macroscopically, it can present as a solid and cystic mass, and microscopically, it can resemble endometrioid carcinoma. So it has a similar presentation as endometrioid carcinoma of the endometrium, has back-to-back glands with little intervening stroma and very atypical looking glandular cells surrounded by desmoplastic stroma. Brain tumor presents as a small solid tumor, and it's composed of nests of transitional cells resembling urothelial cells, as you can recall, which lines the bladder and also the ureter. It can also be composed of columnar cells, and these cells are surrounded by the dense fibrotic stroma. There are also entities known as germ cell tumors, composed of teratoma, germinoma, yolk sac tumor, and choriocarcinoma, and all of them arise from different types of germ cells. Mature teratoma is also known as dermoid cyst. It's bilateral in 10 to 15% of cases. It's characteristically unilocular, contains hair and also sebaceous material, or this oily-like material you see here. 1% can undergo malignant transformation like squamous cell carcinoma and other cancers, and it may present as a solid mass composed of benign-looking collections of tissues which can be heterogeneous, and it's derived from all three germinal layers like endoderm, mesoderm, and ectoderm. Histologically, it's a cyst lined by stratified squamous epithelium with underlying sebaceous glands. So this is the squamous epithelium with sebaceous glands, and this is a hair follicle, part of the skin adnexal structure. And this is a smooth muscle. You may also see cartilage, bone, and thyroid cells as well. There are other types of teratoma. One type is monodermal or specialized teratoma. It is rare, and the types include struma ovary and carcinoid tumor. Struma ovary is composed of entirely of mature thyroid tissue, and it may cause hyperthyroidism. And carcinoid tumor may cause carcinoid syndrome. And another type is immature teratoma. It resembles embryonal and immature fetal tissue. Is chiefly in prepubertal adolescents and young women, and it may penetrate the capsule of the tumor and spread locally and distally. Histologically, it can present as varying amounts of immature neuroepithelium, cartilage, bone, muscle, and other elements, and grading depends on the proportion of the immature neuroepithelium. This is an example of struma ovary, which is the thyroid tissue that you can see here with the thyroid follicles containing the colloid and within the ovarian stroma. And this is immature teratoma. So you can see this immature neuroepithelium here and here. It's sort of like a gland, but it's not exactly a gland. It has neuropils within it. So this is an immature neuroepithelium. If you have read about male reproductive system pathology, you will have learned about testicular seminoma. So there is a similar morphology to testicular seminoma that can happen in the ovary, for example, and this is called dysgerminoma. So 50% of malignant germ cell tumors is composed of dysgerminoma, and 75% of this tumor occurs in second and third decade. Microscopically, it is usually unilateral, and the size ranges from barely visible to filling the entire abdomen, and can be solid yellow, white to gray pink appearance in cut section, and it's soft and fleshy. So microscopically, it's similar to seminoma. It's sheets of cords of large vesicular cells. So these are the vesicular nuclei here with clear cytoplasm. There are some clear cytoplasm here, but some of them are more eosinophilic. There will be centrally placed central nuclei. So if you can imagine like this, it has a centrally placed nuclei within the cytoplasm, and there's intervening scanty fibrous stroma infiltrated by mature lymphocytes. So these are the mature lymphocytes scattered in between. So the characteristic feature for dysgerminoma or testicular seminoma is aggregates of these large vesicular cells with scattered lymphocytes in between. And it sometimes can be associated with a granuloma. Yolk sac tumor is also known as endodermal sinus tumor. It can happen in children and young women. It's malignant and it expresses alpha-fetoprotein or AFP. The characteristic feature is Schiller-Duval body, which is a glomerulus-like structure composed of a central blood vessel enveloped by the tumor cells here within a space that is also lined by tumor cells. And there is conspicuous intracellular and extracellular hyaline droplets that may be present, and is positively stained with alpha-fetoprotein. In this picture, it's a bit difficult to discern where is the hyaline droplets, but may be here, and it may be stained with alpha-fetoprotein. Choriocarcinoma usually exists with other germ cell tumors as well, and is usually known as mixed germ cell tumor. It's histologically identical to the placental lesion, and it expresses high level of chorionic gonadotrophin or beta HCG. It metastasizes hematogenously to lungs and to liver bone, and is often fatal. and this is in contrast with choriocarcinoma arising in placental tissue. So this is a picture of choriocarcinoma arising in a teratoma. This is the squamous epithelial lining of the cyst. Sex cord-stromal tumor arise from ovarian stroma, and ovarian stroma arises from sex cords of the embryonal gonad. In females, there are different types of sex cord-stromal tumor. A more common type of sex cord-stromal tumor is granulosa cell tumor. It resembles granulosa cells of developing ovarian follicle, and you can divide it into adult and juvenile type based on the age and the morphological findings. But majority of the adult type occurs in the postmenopausal women. Macroscopically, you can see yellow cut surface because there is a lot of intracellular lipid within the tumor, and microscopically you can see small cuboidal polygonal cells in anastomosing cords or continuous cords, sheets and strands. There will be called external body, which is distinctive gland-like structures filled with acidophilic material resembling immature follicles, like so. They secrete large amounts of estrogen, and therefore is associated with proliferative breast disease, endometrial hyperplasia, and endometrial carcinoma. It can behave like a low-grade malignancy, and it's associated with increased inhibin. So inhibin is a good biomarker to identify granulosa cell tumor. Fibroma is composed of fibroblast and it's hormonally inactive. Microscopically, it's composed of solid, spherical, slightly lobulated, encapsulated hard, gray-white mass covered by ovarian serosa. And microscopically, it's composed of fibroblasts and interspersed collagen stroma. Thecoma is composed of large spindle cells with lipid droplets. So these are the cells with lipid droplets within it. And thecoma, fibroma, and fibrothecoma are associated with Meigs syndrome. Meigs syndrome is composed of ascites, hydrothorax, and ovarian tumors such as thecoma, fibroma, and fibrothecoma. Sertoli Leydig cell tumor is a functional tumor commonly produces masculinization or feminization. Microscopically, it's composed of gray to golden brown in appearance, and microscopically, it's well differentiated to poorly differentiated. If it's well differentiated, it's composed of Sertoli cells, like here, and Leydig cells interspersed with stroma. There's also metastatic tumors that you have to consider. It's commonly from Mullerian origin, for example, uterus, fallopian tube, the other ovary, and the pelvic peritoneum, and extramullerian such as breast and the GI tract, and also pseudomyxomatous peritoneae from the appendix. There's also an entity called as Krukenberg tumor. It's a metastatic GI carcinoma, gastrointestinal carcinoma, involving the ovaries, and it's composed of mucin-producing signet ring cancer cells, and it's most often from gastric origin. So that's it for the ovarian neoplasms. So the next lecture will be on gestational and placental disorders. Thank you.